Imagine a vital, life-giving river, but one that can suddenly and without any warning act like a totally unpredictable landmine. Well, in the landscape of the human heart, there's actually a blood vessel that fits this exact paradox. It's called the circumflex coronary artery. Now, it's absolutely crucial for keeping the heart beating, right? But its highly unique anatomy, these hidden little variations, and its frankly treacherous location make it one of the absolute most perilous structures a cardiologist will ever have to navigate. Okay, let's dive straight into this explainer. We're going to start by meeting the circumflex artery. Then we'll explore its anomalies and hidden attacks, map out the great cardiac vein, look at the hazards in valve surgery, touch on some electrophysiology risks, and finally, wrap up with the power of imaging. Section 1. Meet the circumflex artery, the anatomy of a troublemaker. To really get why this vessel causes so much trouble, we've got to visualize it. Imagine the left main coronary artery is like a thick tree trunk branching into two main boughs. One of those boughs goes straight down the front of the heart. But the other one, the circumflex, takes a really sharp turn. It dives deep down into what's called the left atrioventricular groove, essentially wrapping right around the side and back of the heart. Its main job? Delivering oxygen-rich blood to the lateral and posterolateral walls of the left ventricle. And since that's the heart's main pumping chamber, it's incredibly important.
To Section 2. Anomalies and hidden attacks. The stealthy myocardial infarction.
You know, normal anatomy is tricky enough, but when nature throws in some structural variations, the circumflex becomes a seriously stealthy threat. It's notorious for these bizarre anatomical anomalies. Sometimes it originates from the right side of the aorta instead of the left. That forces it to squeeze through this tiny slit-like opening and repeatedly compress behind the aorta with literally every single heartbeat. That alone predisposes patients to early aggressive atherosclerosis, but it gets weirder. Some people have rare double or twin circumflex arteries, which makes diagnosing them a total headache. And in some tragic cases, it mistakenly originates right off the pulmonary artery, a condition that can lead straight to sudden cardiac arrest if nobody catches it. And these hidden variations, they play a massive role in how a circumflex heart attack actually looks in the ER. If a standard artery gets blocked, it usually lights up a normal 12-lead ECG with a classic ST segment elevation. Super obvious, right? But the circumflex is a total master of disguise. Because it's wrapped around the back of the heart, its electrical distress signals often just don't show up on those standard front-facing monitors. It frequently presents as a non-ST elevation attack. So to even catch it, doctors actually have to stick extra ECG leads, V7 through V9, right onto the patient's back.
So here is the absolute crucial takeaway. 1/3 of acute coronary syndrome patients with a blocked circumflex show completely normal ST segments. And because those standard monitors look totally fine, there are terrifying delays in getting these people to the catheterization lab for life-saving treatment. This stealthy presentation is exactly why truly understanding this artery is a matter of life and death in the real world.
Moving on to Section 3, the great cardiac vein, an unpredictable neighborhood.
As if the artery's own quirks weren't enough, the circumflex also lives in a super unpredictable anatomical neighborhood. Let's map this out in our heads. Deep in the grooves of the heart, the circumflex crosses paths with another major artery and the great cardiac vein. They all converge into this insanely tight junction known as the Triangle of Brock. It is a very, very confined space, like almost zero room to maneuver. So if a cardiologist goes in and inflates a balloon to open up a blocked circumflex, that lack of space creates a massive risk of causing collateral damage to the vein sitting right next to it.
And this right here perfectly illustrates why this area is so incredibly treacherous. Most of the time, say 60 to 70% of people, the great cardiac vein safely rides over the top of the arteries, superficial and out of the way. But in a massive 30% of the population, that vein takes a dangerous dive directly underneath the circumflex. And you can see how this unpredictable variation.
Just picture this scenario. A doctor is working on a circumflex artery that's heavily calcified. We're talking lined with hard, bone-like plaque. Because the artery and the vein are practically hugging each other in that 30% of patients, an aggressive balloon dilation meant to clear the artery can actually force those sharp, jagged calcium deposits to pop right through the artery wall and accidentally puncture the great cardiac vein right next door. It's a nightmare scenario.
Section 4. Hazards in valve surgery. Caught in the crossfire.
The thing is, the circumflex doesn't just face dangers from the inside. It's constantly getting caught in the crossfire when surgeons are just trying to fix structural issues nearby. You see, the mitral valve sits right next to the circumflex. When surgeons go in to repair a leaky mitral valve, they often have to sew a supportive ring around it. But there's this terrifying, well-known sequence of events that can unfold in the OR.
Step 1. The surgeon places a blind suture into the valve tissue. Step 2. Because the circumflex is hiding right there in the groove, the suture accidentally grabs, kinks, or completely ties off the artery. Step 3. The heart is instantly starved of oxygen. This triggers immediate malignant arrhythmias, basically chaotic, deadly electrical misfires, and suddenly the team has to pivot to an emergency rescue bypass surgery just to save the patient's life.
Hey, it's not just traditional open-heart surgery either. Even our slick, modern devices put the circumflex squarely in the crosshairs.
Which takes us to Section 5, electrophysiology and ablation risks. Electrical spasms.
Now, you'd probably think non-surgical treatments are a lot safer, right? Well, not exactly. Even electrical therapies, electrophysiologists will fix abnormal heart rhythms by threading a catheter into the left atrium and literally burning away the misfiring tissue with radiofrequency ablation. But because the circumflex is running just millimeters beneath that atrial tissue, the thermal heat from the burn can irritate the arteries so badly, do a live intraoperative angiography, taking real-time X-ray movies of the heart mid-surgery, just to deliver spasm-relieving meds. So let's take a step back. We've got an artery that hides heart attacks, totally tangles itself up with nearby veins, gets crushed by valve devices, and violently spasms from electrical heat. How on earth does modern medicine fight back? How do cardiologists navigate this minefield safely?
That brings us to our final part, Section 6, the power of imaging, mapping the minefield.
Turns out, the ultimate answer isn't a sharper scalpel, it's a way better map. Advanced imaging is really the hero of our explainer today. Cardiologists use a very specific arsenal of tools to navigate this treacherous terrain safely. You've got transthoracic echo, or TTE, which is awesome for a rapid bedside check to see if the heart wall is moving right. It gives stunning 3D spatial orientation and scores the calcium levels, though, yeah, it does use some radiation in contrast. And finally, cardiac MRI is just totally unmatched for characterizing the actual heart tissue without any radiation at all, even though it does take quite a bit longer to run.
But the biggest thing I want you to take away from this is that imaging is not just about snapping pretty pictures. It's active, life-saving procedural planning. Doctors are using CT scans to spot weird, anomalous origins before they ever try replacing an aortic valve. They're using ultrasound from literally inside the blood vessel to pick the exact right drill burr down to the millimeter so they can grind away calcium without puncturing that great cardiac vein we talked about earlier. And they're meticulously measuring out the strict 2 mm and 8.6 mm safety distances before they ever dream of deploying a structural clip or a valve ring.
As the experts keep emphasizing, getting imaging info on the circumflex artery and seeing exactly how it relates to the surrounding cardiac structures is absolutely critical for understanding its spatial orientation. Those are over. We simply have to respect the spatial anatomy before making a move. Because at the end of the day, understanding the unique, hidden vulnerabilities of the circumflex coronary artery really is the only way to tame it. Whether you're dealing with a stealthy heart attack, trying to navigate that incredibly tight triangle of Brock, or trying to perfectly place a microscopic valve clip, the greatest tool in modern cardiology isn't a fancy scalpel or a high-tech stent. It's the multidimensional map you build before you ever make the first cut.
Which leaves us with a pretty fascinating thought to chew on. As our medical devices keep shrinking down to microscopic levels, and as our structural interventions get even bolder, how will the next generation of real-time 3D imaging evolve to completely eliminate whatever blind spots are left in the human heart? Well, until we get there, the circumflex remains this incredibly beautiful, complex puzzle for skilled cardiologists and honestly for anyone fascinated by the engineering of the human body.